The art and science and psychotherapy, what does the research say? I also want to thank our panelists for taking the time out for what I hope will be a very lively and interactive dialogue. I wanted to talk a little bit about the format of the way this panel is going to work today, and then we can maybe go from there. First of all, what I'll be doing for the first half is directing questions to maybe one panel member, but my hope, and I just explained this to the panelists, that it'll be as interactive as possible. So I'm hoping that other panel members will jump in and respond to questions or dialogues or points with that. In the second half of the Grand Rounds time, I'm going to be taking questions from the audience, and with questions from the audience, I'll be repeating the question just for audiovisual purposes, so that'll give panel members just a quick second to kind of think about how they want to react. Let's see. Before I go any further, I just want to thank our panelists for coming, and then also just mention that Dr. Arkowitz, Dr. Bootson, Dr. Pritchard, and Ms. Perkins have nothing to disclose as well. So before we get started, I think as the best way of getting started, I'd like to start with some maybe 3-minute introductions, and I'm going to let panelists introduce themselves. When you do your introductions, if you can maybe just say what your name is, where you work, or what you do. Also, your clinical and research experience with manualized treatments, as well as your clinical and research experience with non-manualized treatments. Okay? Go ahead. Yeah. Okay.
Hi, I'm Suzanne Perkins, and I am a clinical social worker. I work at the VA hospital in the PTSD clinic. I've been there for a little over 5 years. It was 5 years in October, but I've been with the VA since I finished graduate school in 1998. My experience with manualized treatments has been just over a year. Was trained in 2 different manualized treatments for the treatment of PTSD back in about 14 months ago. And prior to that, for the first 4 years in the PTSD clinic, was doing non-manualized treatments, and then also doing some group work that was not full-time with the VA with non-manualized treatments too. So.
Do you want to just mention what type of manualized treatments you've done?
The treatments that I'm doing in the PTSD clinic are cognitive processing therapy and prolonged exposure.
Do you need me to use the mic?
I think so for audio visual, because this is going to be broadcast.
Okay.
That'd be great.
My name is Hal Arkowitz. I'm on the faculty in the Department of Psychology on the main campus. I also have an appointment in psychiatry. It boggles my mind that I came to Arizona 33 years ago, and that may actually make you think that I'm old, but I was actually a 2-year-old precocious child when I took the appointment, so you may get the wrong impression. I mainly focused on psychotherapy research and understanding the nature and treatments for anxiety and depression. I've done research using manualized treatments. Throughout my career, I've maintained an active clinical practice and very much value the interplay between research and practice. Just a little plug, I think universities are now moving more toward a clinical science model, and professional schools are moving toward a practice model. So I'm one of a dying breed, or I hope I'm not a dying breed, trying to maintain the scientist-practitioner identity. My private office is on Tucson Boulevard, and the psychology department is obviously west of Campbell. And if I ever write my professional autobiography, I'm going to call it Crossing Campbell Avenue. Because it really strikes me how different those worlds are and how unfortunate it is when I visit the world of practice and visit the world of research. And I value learning from both of them. So.
This is working, yes? I'm Barbara Pritchard. I'm a clinical psychologist and also a clinical associate professor here in the psychiatry department. And I have a almost full-time private practice in addition to my appointment here, where I teach seminars on psychodynamic theory and therapy. And I've also had experience working with manualized treatment in the form of the cognitive behavioral analysis system of psychotherapy, affectionately known as CBASP, which was developed by Jim McCullough, a psychologist in Virginia, for the treatment of chronic depression. The department here has participated in at least 3 studies utilizing that therapy approach, 2 of which have been multi-site studies, the first of which was a 12-site study that the findings of which were published in the New England Journal in May of 2000, and most recently a revamped study, the findings of which are currently being written up. And that was quite an experience, having come from a model that did not entertain manualized treatment much at all. And it's an experience I'd like an opportunity to talk about if we get a chance. But that's been probably my primary experience working with manualized treatment.
So I'm Dick Bootson. I'm a professor in psychology and in psychiatry, and I run the insomnia clinic here in the psychiatry department, which is a small portion of my time and commitment. So most of my time is on main campus in terms of various activities of research, teaching, and training. And in terms of what I've done with manualized treatments, I've never learned a manualized treatment. I've written manuals for treatment. And somebody recently asked me, well, where was I trained? And it stumped me because it never had occurred to me that I had been trained. So I was, so I actually am older in a number of years in the academy probably, or longer than a number of years in the academy than Hal, but I think we'd probably be close. But I date my beginnings from before there was time. But I'm happy to talk about the issues that are associated with trying to develop manualized treatment and how one tries to bridge the kinds of things that Hal was talking about in terms of practice versus research and the advantages of having a research base in clinical activities as well.
The mic. Yeah, there's not a mic today. Thanks. So actually, I'm going to direct my first question to Dick. Dick, what would you say are the benefits, and again, after Dick responds, I'm certainly happy to hear other responses. What would you say the benefits are of using manualized therapy approaches, and if you could address this on a patient level, a practitioner level, and maybe even on organizational levels, that would be great.
Well, so I'm going to broaden the question to some extent to talk about why it might be useful to use the methods of assessment, training, evaluation that we use in research in a clinical activity. And manualizing the treatment is just one aspect of that. And in research, it's desirable as a way of trying to describe and standardize to some extent what the intervention is, so that you have some sense of it not just being kind of the individual capability of therapists, but there often are therapists, strong therapist effects even under those circumstances. But in research, I think and the advantage of kind of paying attention to that when one thinks of how one deals with patients, one's own patients, is that there's a lot of focus on assessment and on continuous measures and seeing whether or not the person's improving or not improving. And I think that kind of feedback is often very desirable, whether it's in research or whether it's in practice. The manualized treatments, manuals, I think, have actually changed quite a bit over the last 15 or 20 years. And many of the critics of manuals, of using manualized treatments, in the sense of that you can't think of everything to put in a manual, and how do you individualize within the manual, and how do you deal with situations that don't quite fit the manual. I think they're more focused on developing guidelines, and in many senses it's a way of trying to incorporate empirically supported principles, not just empirically supported packages of treatments. But the idea of trying to build from some empirical base, I think, is the core of what we do, even if we modify that in some ways and try and broaden it and individualize it.
Suzanne, do you think you could talk maybe a little bit in expanding on the benefits of manualized approaches to talk a little bit about organizational levels? The VA is a federalized system that I know is making a lot of changes there right now.
Yeah, I'm not an expert in this. I didn't actually read the whole package, but there's a uniform service package throughout the VA. So this is a nationwide process by where we want to have our veterans anywhere in the country be able to go into any VA, any clinic, and get the same care. So it's quite an undertaking, as you can imagine. We've had some practitioners in the VA who have been there for decades. But what that means is essentially in the mental health that we are providing specific treatments that are evidence-based. And so we're all having this rollout happening. We are being trained, we are being supervised to provide this treatment to our veterans. So from an organizational standpoint, especially with a nationwide process or organization like the VA, is to be able to say, if I'm working with a veteran who's going to be moving to Colorado, it's quite easy to contact folks in Colorado and help with that transition. I think it also is helpful for us to be able to say that even people in rural areas are getting the same great care that they're getting in larger cities. So from an organizational standpoint, I think that's really helpful. I do also find that when I compare my work with non-manualized protocols, and again, I work specifically in the PTSD clinic, that compared to the manualized treatments is that they're extremely efficient. I get great results and I get them much faster than I used to. And we have a lot of clients who really appreciate that. Taking the time out and dealing with a large system, coming to the VA takes time. Dealing with the appointments, there's some factors there that they have a life outside of here. So being able to have great care efficiently, I think the manualized treatments have helped me to do that.
Well, let's mix things up a little bit, shall we? I do think there are some advantages to manualized treatments. They focus on a particular problem. They're efficient in targeting it. That being said, I'll get on to the stirring the pot piece. I think that I agree with Dick's point that about the emphasis on principles of change rather than techniques of change. Manuals are primarily techniques of change. And I think if we know a principle like exposure for anxiety, or just take that as an example, there's a million ways you could implement that usefully. The manual is just one version of it, and a rather fixed version, and one that doesn't allow a whole lot of flexibility, allows some, to deal with individual differences. The manuals are also, and this relates to ESTs in general, addressed at target symptoms of Axis 1 distress. Certainly those are anxiety, depression, eating disorders, etc. Certainly those need to be addressed. But a study by Kessler showed that fully 50% of people who seek psychotherapy don't have an Axis 1 or Axis 2 disorder. They have problems in living that are serious. And manuals that focus on particular focal targets just don't hack it in terms of dealing with that. And that certainly characterizes a lot of the people I see in my practice. Manuals were developed for research, not for practice. They were a way to try to operationalize what we're doing in research. And I think that their carryover into practice has been very mixed as far as I'm concerned. I've never followed a manual like Dick, I never will, but I do follow principles of change because I think those are much more important. Last comment, and then I'll pass it on to Barb, is the manuals focus on the symptoms, as defined by Axis 1 primarily, and some on personality disorders. I keep calling him Sir Henry Osler. I think it's Sir William Osler, the father of modern medicine. Anyone know? Let's see, I have a variation of his quote. He said, "We not only need to treat the problem the person has, but the person who has the problem." And without going into it, I'll leave other people to respond. I think the manuals treat the problem the person has. And by not treating the person who has the problem, I think they're far less effective than they need to be and address far fewer of the kinds of problems that concern people than they ought to.
So I'll walk out on that limb with you a little further. 2 points I'd like to make, if you'll indulge me. One is that there was this lovely little follow-up study, a post hoc study to the 2000 New England Journal of Medicine study I was mentioning on CBASP that investigated relationship variables during that study and found that those therapists who were supervisors in the study, site supervisors, or who had a psychodynamic orientation achieved the best results. In a study that used a primarily cognitive behavioral approach to chronic depression, although it does have a strong transference component in its treatment. And this was an interesting finding which they the authors interpreted as those more seasoned clinicians and those from a psychodynamic background were better at an approach that used a blend. And rather than following just a manual, if you will, very stepwise, which CBASP has, they were able to draw on their clinical experience and work with the parameters of the manual in getting the best effect. Now, this is interesting because our experience in working with this manualized approach, including the subsequent 2 studies in which I was the site supervisor working with other therapists, is that initially therapists would feel very hamstrung and struggled greatly with working within the confines of the manual. And only when they really got comfortable with it and using it flexibly, still following, if you will, the outlines of the structure of the manual and still meeting criterion when it came to application of the manual, but not losing sight of their skills as a clinician, do they do a better job? The second step that really calls for just a little bit of a history lesson. Those of you who know me in seminar know I'm just notorious about this, but really has to do with the EST movement anyway, that empirically supported treatment movement that started over 10 years ago was really in response to the psychiatric guidelines of the time that tended to understate the benefit of psychological treatment. And so researchers into psychological treatment at the time said effectively, so let's counter this by going about studying psychological treatments, essentially applying the same model that's used pharmacologically, adopting the US FDA model that says this treatment intervention is either supported based on the evidence and therefore to be used, or not supported. And of course that evidence was derived from randomized clinical trials where patients, subjects of course, were randomly assigned to the active condition versus the designed to be inert condition, which in psychological research tended to be a no treatment condition of waiting list or assessment only and so on. Essentially using that model because it was felt that would be taken most seriously. It also had brevity built into it because every researcher loves that. The longer the treatment, the more within group variability you have, the less able you are to make conclusions about causality and so on. Well, again, the problem with this is its narrow scope in order to preserve internal validity meant, yes, narrowing down to one condition or syndrome, which is why when you read studies, you see all those exclusion criteria at the outset. And patients don't present that way. It's really the exception, as Hal was pointing out, when a patient presents with one clinical syndrome. In fact, co-occurrence is more the norm. Co-occurrence either with another axis 1 syndrome or, more often too, with an axis 2 syndrome. And of course, that's a poorer predictor in terms of outcome, including in efficacy studies. So unfortunately, empirically supported treatment research has been based on this model, which really doesn't apply well to the psychiatric population. And if you take it a step further, there are, thanks to the research benefit, by the way, of Donna Bender and Andy Skodal and their group, who have figured out for us there are 256 ways of defining a borderline based on DSM. So in the real world, when we're faced with a patient who walks through our door, and even the patient who presents for a research study, trying to narrow them down to a nicely circumscribed disorder that can be researched in that way, much less treated, is really pretty artificial. If you consider that, and then you consider outcome research that says, yes, most patients will improve to maybe a 50% point on almost any treatment plan that they're put on, any treatment that's applied. But in terms of recovery, maybe only 30 to 40% reach recovery. That means there are still 50% of patients walking out there who haven't improved, and maybe 60 to 70% who haven't recovered, that we haven't reached with our short-term, empirically supported, manualized treatment approaches. What do we do with those patients?
Can I just add one?
Well, actually,
You have a mic ready to
Well, just Barb's last comment, that, you know, characterizing it about 1/3 of people are in remission, 1/3 are improved, and 1/3 are not helped. In general, I have a hard time calling that empirically supported, especially when what it's beating is usually nothing, no treatment. So, I mean, and the other thing I would add is the independent variable, so to speak, in this research, the manual, is usually 16 hours of human interaction. Try submitting that to an experimental psychology journal and they'll laugh in your face. So I don't know how much manuals really do to improve the science, and I don't know how empirically supported these treatments are. We have some data on them, and the data are promising. I'm certainly not denying that. But to reify them, as I think some in the field are doing, given these results and add the 40% relapse rate, and we're far short of empirically supported.
Okay, so so we've drawn some lines. Certainly have, I feel, appropriately provoked. So one thing, let me give a different perspective of some of the history. And it goes back a lot more than 10 or 20 years. For one thing, in psychology and therapy within psychology, certainly when I was in graduate school, the view of psychotherapy was that there was one intervention that was good for everything. It didn't matter what the problem was, that psychotherapy, insight-oriented psychotherapy in one form or another, was appropriate for all, no matter what the problem was. And what changed over the decades that followed that was a sense that we could develop interventions that were specific to particular kinds of problems. Now, that doesn't mean, and certainly there's been an evolution of what's the nature of the patient and what's the nature of the evidence. And one of the reasons in medication studies, for example, that there are so many exclusion criteria is that you first want to show that the medication actually works for something that they're going to market it for. And they want to make, you know, and eventually, when DSM-3 came in, there was kind of an attempt to try and match interventions according to the various diagnostic categories. But as, you know, as the years went by and interventions were developed and supported by NIH, and this was true of psychological interventions as well as medication, there was an attempt to see to what extent the problems that were embedded with other comorbid disorders also responded to these interventions. So it's no longer the case that interventions, particularly psychological interventions, are not evaluated, are only evaluated with kind of pure cases of the intervention. That's hardly the case for any manual that I'm aware of. Ron, did you want to say something?
Apparently I did.
And so I think a good model actually within NIH for the development of psychological treatments has been at NIDA, the National Institute of Drug Abuse, and which has been directed by Lisa Onken. Only coincidentally that I was on her graduate committee for her dissertation. But she's essentially tried to have NIDA, which you know, which has been very drug-oriented, very medication-oriented, try to develop what are the psychological interventions that could be used within substance abuse using an FDA model, as Barb was describing it. But the first stage of an FDA model is to develop the treatment. And it's often done in ways that aren't appropriate for clinical trials because there's a lot that has to be done to try and understand what the interventions are likely to, which ones are effective, what are the causal mechanisms that might be required, et cetera. And it isn't the case that psychologists or therapists or clinicians who are doing research are not interested in mechanisms of action. They're very interested in them. And they try and develop interventions that address those mechanisms. And as one does research trying to develop a treatment, they go to a second stage where it's not just the development, but then it becomes the verification. And treatments are not going to succeed if the only alternative intervention is waitlist control. They're not going to get funded. They're not going to make it in the marketplace. They have to show that the treatments that are being developed outperform other treatments, that might be commonly used, or outperform appropriate control groups that help you to specify what the theory and the mechanisms are. So I think the whole research enterprise around therapy has become much more sophisticated with regard to that. And by the way, we have Hans Eysenck to thank for that, because Hans Eysenck in the early 50s essentially attacked psychotherapy research of the time by saying that we didn't know anything and that one can produce 2/3 improvement in the control groups and that no treatment has ever outperformed that. And that produced such a revolution in the amount of research that was put out by the clinical community that we now know a lot in terms of what does work and what doesn't work. In a way that Eysenck, I think he'd be embarrassed to have to take credit for kind of actually supporting all the therapy research. By the way, just as an aside, Eysenck, around the end of the Second World War was also the beginning of accreditation of clinical psychology programs. And Eysenck advocated that there should be no teaching of psychotherapy or interventions for treatment because we didn't know anything about interventions for therapy, and that there were things that we had empirical evidence about with regard to assessment, for example, but not therapy. And it was partly that because of the argument that he was making about, that he made more broadly that essentially started the field. And finally, I want to say that therapy can hurt. There are times when interventions don't only help, but that they harm. And if it was all just common factors that was the effect, then it's unlikely that we would have iatrogenic effects. We would have a variety of things in which therapies hurt. And I think you can actually learn as much from the principles of change from looking at therapies that harm as you can from therapies that help, where it's confounded often with expectancies of change and a variety of other things. Okay, well, I don't want to just out-talk everybody else.
No, actually, I was going to ask you, if you could address some of that, from more of a practitioner perspective, if you could address some of the issues about comorbidities, that'd be great.
I don't believe I've ever had a client with just one Axis 1 diagnosis. In that, the VA PTSD clinic, we have a lot of complex patients with a lot of co-occurring disorders. One of the reasons I really like doing prolonged exposure, for example, is that there's very few exclusionary criteria for prolonged exposure right now. In fact, Dr. Foa just completed research with folks who are still either using or abusing alcohol and still had good outcomes. It was, starting with higher levels of symptoms and ending with higher levels of symptoms than those without substance abuse problems, but they still had the same treatment effect. For me, that means a lot. We have a lot of veterans with PTSD who also are struggling with substance abuse problems who aren't ready to be abstinent. So this gives us a treatment option for them to help treat their PTSD, whether or not they're going to choose to truly treat their substance abuse problems. So I don't find this to be a problem with my clients who rarely have just a PTSD diagnosis.
Right, another question. And so I'm kind of addressing to the whole panel, but if maybe Barbara could start with addressing this, that would be great. Is it ethical to use other treatments when we have empirically supported approaches that we know works? So, and this is especially if the empirically supported treatment hasn't been attempted first.
No.
Okay.
If I understood the question correctly, if we have an empirically supported treatment that works, and why wouldn't we use it? If it's briefer, cost-effective, essentially, why wouldn't we use it? And this, of course, from someone who's primarily psychodynamic in her orientation. I mean, absolutely. I think the embedded question maybe that I'm hearing is has more to do with what do we do when it doesn't work, and that's a question that pulls, of course, for the issue that more research is needed and so on, which I think all of us would agree to. But of course, if there's an empirically supported treatment that works, and if one really believes that it's empirically supported, then why wouldn't one use it? Okay. But the last point may be the point.
Yes. And the problem has to do with the problems of empirically supported treatments. We can learn from them. I use them as part of my psychotherapy practice. They have a certain value. One thing we don't know, in fact, there's some evidence that I'll mention, is do empirically supported treatments work better than what clinicians in the community are already doing? Before we start to tell them what to do, shouldn't we find out what they do? There are some studies, they're very difficult studies to do. Bruce Wampold published one with lots of flaws in it, not because of him, but because of the nature of the data. But his and other studies really raise the suggestion that there may not be much difference in efficacy between what clinicians are doing in the community as non-empirically supported treatments. The other thing, to raise a funny question here, is this is assuming that there are the researchers and the practitioners. And the practitioners are discrete groups from the researchers. I know Varda hates this term, but George Stryker used the term, the clinician is a local scientist. What did Freud do? He made observations, formed hypotheses, made observations to see if they're consistent or inconsistent with his hypotheses, modified his hypotheses appropriate to his observations, and in fact changed his major theories 3 times. So there's an assumption here that research as defined by the randomized clinical trial or the logical positivism that we're doing is the way to know. I'll just conclude what I can go on for several hours by asking how many subjects in how many control groups did Charles Darwin run?
If I could real quick. You make me think of a patient I saw who had OCD, who had consulted one of the preeminent figures working with OCD in the country and ended up being referred to me somehow. And for whom I thought, sure, the empirically supported treatment for how he presented would be cognitive behavioral therapy and meds. And of course, the person who assessed him, this preeminent researcher, had recommended that, but without appreciating what began to emerge even in the first session with him that I had, is that he was so hyper-vigilant about his body and his reactions to meds that he wouldn't take meds. And there was such shame for him around his obsessions and compulsions that he refused to talk about them. So what should have been a pretty, straightforward case of working with an empirically supported treatment on 2 fronts couldn't work with. And of course then took a more psychodynamically informed approach that started in terms of working with him around his shame and incorporated strategies and so on, but does that speak to, was it unethical that I didn't use that empirically supported treatment approach with this man? Well, I couldn't. I mean, with that man in my office at that moment, that treatment approach was not possible. And I think it speaks not only to, is there really good evidence for any given EST, but also who is that person sitting in front of us? Back to your quotation, Hal, And will it work with that person? And that's a call to be made by the clinician in the moment. So,
My short answer is no, since we're all starting with the short answer. I love ethics questions, right? But I think the ethical issue is that we're doing informed consent with folks. If we provide them with the information about what we know to be supported in what way, and they have a right to choose what they want to do. So I think as long as we cover informed consent, and if there's somebody who does not want to use an approach that we would use in a manualized treatment, then that would be their choice. They wouldn't be working with me, but I could refer them to somebody else.
So my short answer would be maybe. And I think the usual illustration, at least the illustration that I've heard often, is, well, shouldn't Barlow's treatment for panic disorder be known about in any clinical training program in which they might be dealing with panic patients? And would it be considered ethical to train people in a way that they wouldn't even know that such treatments existed because of their particular approach? And often the example is given of some psychodynamic or psychoanalytic program, and would it be ethical for someone to go to a psychoanalytic program where they never learn about alternative treatments that might be quite effective? And that probably is less a case in real life, that people now, treatments that are effective become learned. Everybody wants to be able to help their patients, and it probably is the case, as Barb mentions, that it becomes more of an issue when you have roadblocks or you're not being very successful, and you think of what the alternatives are to the treatments that you're aware of. So I'm not sure, but I would agree that none of the treatments are perfect for everybody. Nobody has a 100% success rate. And there are always circumstances in which you might think, for this individual, that's not the best place to start. That you know what the alternatives are, and you make a different decision as a way of trying to begin. I don't see any problem with that, but I think it's a question of, do you know what the alternatives are, and are you aware of them, and either in terms of being able to refer to people that you might think would be appropriate, or have learned them yourself. You can't learn every possible empirically supported intervention because of the way people are talking about it, and certainly there's no training program that could possibly accomplish that. And that's one of the reasons for the focus on principles rather than just treatment packages, because you can learn the principles and you can see how they might be applied. One of the dangers, however, that we should all be aware of is that our judgment as therapists, and by the way, I have both hats and I try and do both at the same time, and so I object to the notion that researchers are not clinicians, or even that most researchers are not clinicians. That's not true of the people I know. But there have been studies of how good is our judgment and what are the outcomes when we decide to deviate from the manuals that are available for some of the ones that are more typically researched. So CBT for depression, for example, a number of studies have shown that when clinicians say it's time to deviate, this is what I should do, they tend to do worse than clinicians who are stick to the manual better. So it's a question of how good the manual is and how appropriate it is for the kind of problem that you're seeing. And many times it may not be appropriate, or a person is not making progress. And I must admit that when I see patients, I make a lot of decisions about when to introduce something, what order I want to introduce it, at what point do I think, might this be too much, may they be overwhelmed with information. I'm sort of thinking about a variety of things that I might want them to do in order to change a particular pattern so that their sleep will be better. But I want them to actually accomplish it. I don't want to just give them a list so that they go away with a list and say, I got great advice and then never do it. So the idea of trying to actually implement it and being sensitive to what are the barriers, and sometimes they may be psychological barriers, as Barb mentioned, and I think, so I don't think there's any fundamental disagreement about that. It's just that we have to be aware that we have various kind of heuristics, shortcuts, biases, that we often use information that may not be all that grounded, and we have to kind of protect ourselves from doing that. And one of the hardest things for any clinician to do, at least from my experience, is to actually have follow-up data on their own patients. It's fairly, and it wouldn't be difficult, to enlist secretarial help or clerical help to follow up a month or two after the patient has been discharged to see how they're doing, or 6 months later. And some clinicians have done that, and I think it's usually been extraordinarily informative, that we kind of avoid, it's kind of a self-protection, that we know what we see when they come in and what they tell us when they're in the session, but we avoid more independent information about how well they're doing afterwards. And I think just that piece, which is really taken from more of a research focus, would make our clinical practice a lot better.
So now I'd like to open up the panel to questions from the audience. Yeah, Barda.
Well, I'm sitting here thinking, first of all, this is a wonderful panel, so thank you so much. And, I'm sitting here thinking whether this panel, the specific answers that or positions that we heard here, would be different if we talked about it like 5 or 10 years ago. What's very special for our time, we are facing an enormous, enormous crisis. And it combines at least two dimensions. One is the financial crisis, and along with it, the health care system crisis, and within it, the mental health, the crisis in the mental health field, and the parity bill that recently was passed doesn't make it any easier. It makes it easier maybe on some of us, but it makes the whole system different. And at the same time, as Suzanne well articulated, we have tons of veterans coming back from Iraq, and we need cost-effective treatments to address this without collapsing the whole system. So I'm wondering, how are you thinking, anybody in the panel, but maybe especially Hal and Barbara, are you thinking differently now that we are facing all these multiple problems in the real health problems? And the other piece attached to it is that I would like us to think beyond the depression and anxiety, back into what Dick mentioned as drug abuse and multi-problem systems, family systems out there with family violence and all that. So I think a lot of the polemics in psychotherapy research focus on the individual depressed and anxious. Not that they are not important, but we could open that. But I first want to ask them today first question. Thank you.
I agree with the need for shorter-term, cost-effective treatments. I don't think that they have to be done, I'll give you some examples in a moment, you probably know where I'm going to go, in a way that ignores the person as much as I think the ESTs do. Motivational interviewing is something that I've been interested in. 75% of it is Carl Rogers. Less than 10 sessions of motivational interviewing, 16 sessions, have profound effects. It's very cost effective. And it has a little technique in it. But it has more of Carl Rogers' appreciation of the person, getting into their world, the focus on empathy. And it's effective. Psychodynamic therapy, psychoanalytic therapy. Very early in the study, but I would cite one study that people have taken issue with before, a very nice study by Barbara Milrod and a whole bunch of other people for short-term manualized psychodynamic treatment for panic disorder. And the effect size was in the ballpark of what Dave Barlow gets with his very good cognitive behavioral treatment. One study does not make whatever it makes, I don't know. But it certainly starts something. I mean, The question here is, maybe we can have treatments that pay more attention to the humanity of the person than I think the technique-oriented ESTs do, and it can be done in a cost-effective way. In fact, motivational interviewing, as you know, is sort of noteworthy because it'll often get its effects in 3 or 4 sessions, even less than the 16 sessions as in the Project Match study. So I think it's possible to do cost-effective treatments, and I think we need to. But I don't think that we need to focus so much on techniques in order to do it. I think we can also include more factors that address more who the person is and obtain the same cost effectiveness.
That's a tough question for me, in part because of the patient population I tend to deal with, which is largely personality disordered. And the shorter-term therapies do not work as well, simply, for the personality disordered patient. What is interesting, however, including the article that came out in October of last year in the Journal of the AMA that maybe some of you saw cited, that was a meta-analysis of long-term psychodynamic psychotherapy. One of the smaller findings in that was that when long-term therapy, psychodynamic therapy, was compared to what they considered shorter term, so longer term then was 102 sessions versus shorter term, which was 32 sessions. The longer term outperformed the shorter term in terms of the target problems, the general outcome, the level of personality functioning, and so on of the patient populations that were reviewed. And those covered anxiety, depression, eating disorders, personality disorders, and so on. What was interesting, though, is that duration was not a factor. Number of sessions was a factor, but not duration. And I've been thinking about that for a while anyway, in part because the CBASP work, for instance, starts out at a very intensive level, twice-a-week sessions, and tapers off. And in the original study, tapered off to 1 year of maintenance sessions that were once a month, and found a continued effect during that maintenance period. So I'm wondering if one way of being, maybe paradoxically, cost-effective is to really sort of go in like with massive amounts of antibiotics and really help a patient and get in at the level of intervention that is needed and not have it be as prolonged and maybe costly in that way. Plus we know, and I know many clinicians have had the experience of seeing a patient more intensively on an outpatient basis and keeping them out of the hospital as a result. And often writing on those forms that, would get request prior authorizations for additional sessions, be sure to note that, the patient has not needed hospitalization since outpatient therapy began, and so on. And so there are many ways of considering treatment cost effective. So my other thought was about the number of patients I see who maybe are adolescents, where it becomes evident early on that, yes, family work is needed, and where the work may either shift to family focus, and certainly that's cost effective in the sense that the whole family system then gets treated. And whether I do the work myself or might refer them out, which also gets us to the point of available resources in this community, which are very limited. For me, I'm a bit torn because the population I tend to work with tends to need longer term work to effect change at the level of personality structure, which is the other irony, that even as empirically supported treatment has been pursued in the last decade especially, the basic science that's been doing research has been revealing more that personality variables probably underlie why so many patients present with multiple syndromes and multiple disorders, and has been suggesting that the level that we need to intervene at is probably the level of personality structure. And unfortunately, a lot of the brief ESTs don't target that, or haven't. That's changing, including Peter Fonagy's work, Fonagy and Bateman, who have this mentalized, empirically supported treatment approach, that is more focused and structured and is moving in that direction. So
I just wanted to actually emphasize a couple of the points that you made, which to indicate that we have agreement on some things. One of them was that initial effects are often very strong. That's certainly true in cognitive behavioral treatments, and the evidence has been fairly good that if much of the effect happens early in the treatment, even in short treatments. In in 8-week sessions, you can usually look within the first couple of weeks, and you'll see a lot of change. And those initial effects are a very important aspect of it. And trying to capitalize on that in terms of delivering more of the treatment right at the beginning, rather than kind of building to the idea that you don't even introduce treatment interventions until later, because you feel you have a need to kind of get so much education done or some reactions to the patient or support of the patient before you start the intervention is probably unwise. The evidence seems to be that early in treatment is actually a good time, that they come motivated to make changes. It's a good time to change. You usually can get a lot of things done. The other thing is that we would benefit from what Neil Jacobson called the dental model of therapy, which is that booster treatments and yearly checkups, or at least my dentist wants every 3-month checkups, would be a good idea and would be supportive of the kinds of things that we're trying to maintain. We've tried to do without that by having relapse prevention components within treatment, often with less than optimal success, and actually having a model in which people came back regularly and thinking of it more as prevention, or as much as prevention as treatment, I think would be very useful. More and more of the field is moving towards issues of prevention and dissemination, not just immediate treatment. And I think these are things that will actually be very useful in terms of strengthening the results.
Does that mean fluoride might be in treatment?
Well, it's better than Laetrile, probably.
I just wanted to add something briefly with regards to this treating the person versus their presenting problems or diagnoses. I haven't felt like my clients, the person themselves, are in any kind of need of repair. I think that what I have felt actually is a much stronger connection to my clients, especially when doing prolonged exposure. It is in fact their humanness and their compassion that creates such distress following traumas, especially when these are man-made traumas like combat or assaults. My willingness to be 45 to 60 minutes with them in a session of an imaginal exposure is absolutely being connected to that person. So I actually haven't felt like it disconnected me from them as a person. I actually feel like it's been helpful in that process. So I just had to add that.
I did want to say one other thing about crises. You know, this is a financial crisis, and one might think that we're going to be flooded with people who are struggling with a financial crisis. But like 9/11, it did not actually increase the number of people who were seeking out psychiatric or psychological help. I think we underestimate the kind of therapeutic resources within families, within communities that people turn to in times of emergencies and crisis, and that it may actually be a luxury from the individual perspective, not in terms of financially a luxury, but just in terms of time press and everything else, to seek out individual therapy. And so that in general, we may not kind of see that we're being called on, even though it is a crisis and the society and the world is going through a financial crisis, but there are other resources, and we should be thinking about how to strengthen those resources and how we can interact with them in ways that strengthen them.
Let me just add one thing going back to the cost effectiveness. Cost effectiveness doesn't mean short-term treatment necessarily. Ken Howard and his associates, which Dick knows very well, and others here. You what?
I'm one of his associates.
Yes. That's right. So this guy Bootson did this research on the dose effect in psychotherapy. And it's very elegant research. And some later studies distinguished between how many sessions it takes to get 50% or 75% response for different types of problems. And they distinguished between acute distress, chronic distress, and was it personality distress or something? The third one was more a broader construct. And as you went from acute distress, which can be treated, I think they found something like a 75% response in 8 to 12 sessions, roughly. And the chronic distress was longer. And the personality factors was up to 2 years to get an adequate response. So we're talking about cost effectiveness, but it doesn't mean short-term treatment. If you take someone with chronic distress and give them 6 sessions, you're saving money, but you're not getting the kind of response that that sort of problem warrants. So the effectiveness piece is reduced, as is the cost.
So, so just a footnote with regard to that study. University of Arizona was one of the sites at which the data were collected. Larry Butler data set was used. And sleep problems did not change no matter how long the treatment was. Now, the question is, why not? Because they're never treated. That's what's basically why not. In other words, it's a complaint for which there were no appropriate treatments being administered. And if you look at the literature about sleep now, it would actually be a controversy that you could treat somebody for 2 years if that was a primary complaint and not change that sleep. And so I think part of it had to do with what was the data set, what was the therapy that was being evaluated over those 2 years. And so it's true that some problems resolved very quickly within a couple sessions, others took much longer, but it had a lot to do with the therapy that was being implemented.
So unfortunately, actually, could I borrow that so I'm not streaming it? We're out of time. I feel like this could have gone on for another hour. But I want to thank all of our panel members for their time. And so thank you again. Appreciate it.